Dear audience, my name is Regina Molnár, and I would like to introduce you to our projects in the context of new insights into the development of abnormal glucose tolerance and cystic fibrosis. I'm a PhD student and part-time work at Translational Pediatric Institute. My supervisors are Andrea Panitsky and Klementina Ochkai, and my vision is that one day CF-related diabetes will not worsen the life quality of CF patients, and as a first step, my mission is to provide new screening strategy for earlier diagnosis. Here you can see a list of our two ongoing projects, which are strongly related to each other and investigate the role of islet autoantibodies in CF. Why did we choose this topic? Because CF-related abnormal glucose tolerance is the most common extrapulmonary complication of CF, affecting every third child and half of the adults. Besides worsening the life quality of the patient, it significantly increases the overall mortality rate and can begin in early childhood, or an endocrine pancreatic dysfunction can present even at birth. This dysfunction is mainly due to physical damage to the pancreas with bystander beta cell death, and with destruction to the beta cells, originally intracellular autoantigens are released, which activates the immune system and drives the development of an autoimmune setting. In type 1 diabetes, the role of islet autoantibodies is well established. According to the TEDdy study, 34% of children with islet autoimmunity develop diabetes in time. However, in CF, screening for such antibodies is with limited recommendation, therefore not commonly used. Because of this, data is missing about islet autoantibodies in the CF population, so with our first project, our aim was to determine if they could contribute to the development of an abnormal glucose tolerance. So we investigated the prevalence of antibodies through a systematic review and meta-analysis. Here you can see our clinical question, and we studied CF patients with antibody measurement, and our main outcomes included the age of onset of an abnormal glucose tolerance and the presence of the listed antibodies, including any on multiple positivity as well. Our hypothesis was that islet antibodies are present in a significant proportion of CF patients with an abnormal glucose tolerance. We conducted a systematic search in 4 databases and a forward-backward citation chasing, and finally 20 studies were included in the analysis. Prevalences and dose ratios were calculated with 95% confidence intervals, and here you can see our analyzed outcomes. So let's move on to our results, and this first aggregated forest plot, which shows us the pooled prevalence of antibody positivity in people with CF. Among the antibodies, the most frequently screened was GOD, and the least frequently screened was zinc transporter 8. We had a high level of heterogeneity due to 2 outlier studies in which a technical issue was discovered in antibody measurement, and more studies had a high risk of bias than a moderate one, which you can see on the right side of the slide, represented by the red columns. Prevalence ranged from 1 to 6%, with lowest prevalence for islet cell antibody positivity and highest for insulin antibody. Any positivity had a prevalence rate of 4%, and multiple positivity had lower prevalence rate with 1%. So in general, low prevalences of antibody positivity were found in people with CF. This next forest plot shows us the prevalence according to glycemic status, where we divided patients into diabetic CFRD and non-diabetic non-CFRD subgroups. We had high heterogeneity on those outcomes where the previously mentioned outlier studies were included, and also more studies had a high risk of bias in this analysis. If we look at the numbers, we can see that the non-CFRD group exhibited lower prevalences by 1–2% in all outcomes, but this difference was without statistical significance, so we found a tendency of higher antibody positivity rate in CFRD patients compared to non-CFRD ones. We wanted to assess this tendency from a different point of view, therefore odds ratios of antibody positivity were calculated between CFRD and non-CFRD patients, with low levels of heterogeneity and unfortunately low quality studies. Odds ratio ranged from 2 to almost 5 and was consistently and statistically significantly associated with CFRD. The strongest association was found for GOT positivity, where more than 4.5 times higher odds were found in the CFRD group. So altogether, higher odds of antibody positivity was reported in CFRD patients. This table summarizes our outcomes eligible for a systematic review, and this overall assessment revealed that an abnormal glucose tolerance presented earlier in antibody-positive CF patients with more complications. The strength of our study are that besides prevalences, odds ratios were also analyzed, and we conducted a comprehensive analysis of several antibodies, including multiple positivity, which is clinically very relevant. And our limitations are that high risk of bias studies were included, and our results were heterogeneous. In conclusion, antibody positivity was detected in a minority of people with CF, but in them it was linked to the development of CFRD with earlier onset of an abnormal glucose tolerance and possibly an increased risk of acute complications. So our implications for practice are that a general screening of antibodies is not necessary in the CF population. However, a closer monitoring is crucial for antibody positive patients. And our implications for research include a risk stratification and more studies focusing on beta cell damage prevention. Currently, we are writing the manuscript from this project and expect to send it out for an internal review this month. Here you can see a list of our targeted journals, and so far we've presented our results into international and one national conference. So let's move on to our second project, where we investigate the role of antibodies in our own patient cohort with a registry analysis. As I previously mentioned, the role of antibodies is well established in type 1 diabetes, and the TEDdy study group recently published a combined risk score which enhanced type 1 diabetes prediction. And the best performing model in this risk score incorporated the screening of antibodies, a genetic risk score, and the family history of diabetes. Unfortunately, in the CF population, we lack information about the possible risk factors contributing to an earlier abnormal glucose tolerance development. Therefore, it is difficult to identify those who are at higher risk. So with our second project, we aim to in-depth analyze a correlation between possible risk factors and the development of an abnormal glucose tolerance in children with cystic fibrosis. So here you can see our clinical question, and we would like to examine a correlation between antibodies, family history of diabetes, and the glycemic status of children with CF. And our hypothesis is that there is a significant connection between antibody positivity, a positive family history of diabetes, and the development of an abnormal glucose tolerance in children with cystic fibrosis. As data source, we are using the CF-related pancreatic disorder registry at Heimpel National Pediatric Institute, which was started almost 6 years ago, and now around 130 children are followed regularly. Here's a table with our eligibility criteria. We have completed data cleaning and currently collecting the family history of the patients and, of course, from their parents. So to summarize our ongoing projects, we are investigating the role of islet antibodies in CF-related glucose abnormalities, first in the form of a systematic review, and as a second project studying our young patients. And I would like to thank you for your attention with a quote from Gessler: "Children are not things to be molded, but are people to be unfolded."
Thank you very much. Congratulations. So overall, maybe you mentioned it and I missed it, but so in cystic fibrosis, there is a damage in the pancreas which causes the diabetes. So as I imagine, there are patients who has no antibodies at all, but still has cystic fibrosis. What is the ratio there? What percentage of patient has antibody or autoantibody, and how many patient has no antibody, patient who already developed the cystic fibrosis?
The diabetes.
The diabetes,
yeah.
Yes.
According to our results, so there is no previous summary of this. They're just small studies investigating patients. But according to our results, the percentage of antibodies is below 10% in CFRD. So the majority don't have or doesn't have antibodies. And yes, it's true that it's because of the destruction to the pancreas, the physical destruction. So I think the question, or why we are doing this study, is that we can see children, for example, with 6 years of age, who already has an abnormal glucose tolerance, as we can't tell why.
I see. Thank you.
I maybe have one. So, do you have any explanation why there is, why there are actually, why there are these antibodies in CFR? Is there some explanation what it could be, and what is the prevalence in general population?
In the general population, the prevalence is around 1-2% according to the literature. And so roughly in the CF population, it's double than compared to the general population. But all autoimmunity, every autoimmunity has a higher prevalence in CF. So this, I just went back because this figure depicts our theory with the bystander theory for the production of antibodies. So it's mainly because with the destruction to the beta cells, the antigens or the originally intracellular antigens become available, and therefore antibodies are formed.
Okay, thank you.
Maybe just one small question.
Yes.
In your current clinical practice, do you screen CF patients for diabetes? I'm sure yes, but
Yes.
when and how often?
Well, according to the current guidelines, the recommended screening starts from 10 years of age with an oral glucose tolerance test, a 2-hour oral glucose tolerance test. But within our clinic, we started earlier, so from 6 years. And it's longer, a 3-hour oral glucose tolerance test with intermediate time points. So we not just measure them at 0 and 120 minutes, but 0, 30, 60, so every 30 minutes to more correctly assess the changes.
All right, and how often do you do that? So you do it at 6 years, and then when is the next time?
Yearly.
Yearly, so once a year.
Yes, at
Yep.
yearly follow-up until, of course, we cannot do them because
Yeah,
they
yeah.
become diabetic and so on.